Uh, if you have a metastatic prostate cancer, you have to give androgen deprivation therapy to start with. And you can be sure that the patient will develop castration-resistant prostate cancer. However, not all the prostate cancer patients will need castration. And we know that. The guidelines identify a subset of patients that should be treated with hormones. Now, if we look at this trial, this is a randomized study of the RTC where patients with clinical T2 to T4 and 0 or N plus prostate cancer were randomized to, they were not fit for treatment for curative intent, with curative intent, and they were randomized to receive immediate androgen deprivation therapy versus deferred androgen deprivation therapy, deferred at the onset of symptoms. Now, if we look at the delayed androgen deprivation therapy arm, you see that at 16 years, only 15% of the patient, 50% of the patient were actually on hormones. And 30% of these patients died, but not because of prostate cancer, meaning that you could spare hormones in a significant proportion of patients, and you could avoid castration-resistant prostate cancer in a significant number of patients. So the first consideration is that probably you should try to stick to the guidelines and to really select the patient where we give hormones in order not to increase the load of castration-resistant prostate cancer. What happens when you put a patient on androgen deprivation therapy? This picture was published on Lancet in 2016, and it's related to two twins, and one of them was put on androgen deprivation therapy 1 year before. And I believe you can easily guess which of the twin has been on androgen deprivation therapy. And if you see this patient, you clearly see the differences between the twin brother. Central adiposity has been increased, gynecomastia, loss of weight. He was 7 kilos more than his twin brother, loss of body hair, etc. But what you don't see in this patient is all the symptoms of the metabolic syndrome. Abdominal obesity is one, but high triglyceride, low HDL, high blood pressure, high fasting blood sugar. And if in the general population the metabolic syndrome is 25%, in patients taking androgen deprivation therapy rises to 60%. Another problem is the risk of bone fracture, which has another ratio of 2.5 in patients taking androgen deprivation therapy as compared to controls non on hormones. And the fatigue related to androgen deprivation therapy, which is really clinically relevant and interfering with daily activity. So we have to be very careful about the overall quality of life of the patient. We have to be sure what we are going to give to the patient when we prescribe the hormones. Are we going to improve survival? But are we sure that the patient wants to live 6 months longer, 8 months longer, or maybe wants to live better? So we have to be very careful. And what about the risk of cardiovascular disease? Because if you have an increase in the rate of metabolic syndrome, are we increasing the risk of fatal cardiovascular disease? I think there has been a lot of debate about this issue when there was a kind of discussion between agonist and antagonist. And in the end, if we are looking at the number of fatal cardiovascular events, they were not really clinically relevant. And probably, if we, again, we look back to the RTC study and we compare the two groups of patients randomized, early versus deferred androgen deprivation therapy, there was no difference in prostate cancer mortality. That's one point. But there was also no difference in non-prostate cancer mortality between the two groups, meaning that probably if the androgen deprivation therapy given at the beginning doesn't do any effective result for the disease, it doesn't cause any way death for the patient, not related to prostate cancer. And again, in this large population study on 66,000 patients in USA, actually there was no difference in overall survival at 15 years for patients belonging to areas where there was a high prescription of hormones as compared to areas where there was low use of androgen deprivation therapy. So again, this probably tells us that taking or not taking androgen deprivation therapy doesn't really cause a non-prostate cancer mortality. What about the fear of a cognitive decline? Well, this has been addressed in this study where 77 patients with non-metastatic prostate cancer who were on continuous androgen deprivation therapy were compared with 82 patients with prostate cancer not taking androgens, and a healthy control group of 82 patients. And they did 14 neuropsychological tests in these three groups. And after 36 months of androgen deprivation therapy, actually there was no difference from this group as compared to those who were not taking androgen deprivation therapy, meaning that probably the cognitive decline cannot be measured, so probably there is not really a major impact given from hormones. So this is a message that androgen deprivation therapy has side effects, but probably is not really causing major side effects. The question is, how can we control the side effects of androgen deprivation therapy? Is intermittent androgen deprivation therapy a way out in order to reduce the side effects? Apparently not, because in the SWOG randomized study on 1,000 patients, actually there was no difference between the two groups in terms of diabetes, in terms of obesity, osteoporosis, fracture, etc. So intermittent androgen deprivation therapy is not a way to reduce the side effects. I think that the only reasonable thing that we should suggest to our patient on androgen deprivation therapy is physical activity. And we do have some evidence. This is a meta-analysis. Well, of course, a meta-analysis of low level of evidence study showing that exercise can improve the muscle strength, can reduce the BMI, and can even maintain the sexual function in patients taking androgen deprivation therapy. And there is also a positive effect on androgen deprivation therapy related fatigue if you do exercises. And in this randomized study, there was an effect of lifestyle intervention that included training and dietary advice as compared to a control group that were not given these advices. And this effect was shown, was proven in terms of improvement in the endothelium function as assessed by flow-mediated dilatation of the brachial artery. So really doing physical exercises is probably the way to improve the physical functioning of our patient. What kind of physical activity? There has also been study comparing different types of exercises, but the conclusion is that it doesn't really matter the type of exercise, as long as the patient keeps himself fit by doing exercises. So, to improve most of the side effects of androgen deprivation therapy, the only reasonable things to do is to suggest to our patient to do physical exercises. And this is clearly stated also in the guidelines, where there is an advice, a strong advice to give to the patient to modify the lifestyles, diet, exercise, etc., smoking cessation. And the third message, obviously, is do not harm to our patient. Try to stick on the guidelines recommendation for prescription of androgen deprivation therapy. And obviously, when we have a patient who doesn't have a metastatic prostate cancer, we have to keep in mind that our guidelines tells us that we should give hormones if we don't treat with a curative intent this patient. We should give hormones only to patients who have a PSA more than 50 nanogram per mil or a PSA doubling time less than 12 months. If we have a metastatic prostate cancer, obviously this patient needs to be treated with hormones, but if we are in an adjuvant setting, the place of hormones is only combined with radiotherapy temporary for patients who have a high-risk prostate cancer. Thank you very much for your attention.